So let's move on to the next speaker, Dr. Ming-Jer. And Dr. Chen is now the chair of Department of the Obstetric Gynecology and Women's Health of Taichung Veteran General Hospital, and also the director of the Center for Reproductive Medicine. And also he is the prior supervisor and longtime supervisor of TAMIG, Taiwan Association of Minimally Invasive Gynecology. And he is currently the president of TSRN, Taiwanese Society of Reproductive Medicine. And he is always a long time, very good speaker on this topic. And today his topic is the impact of surgeries on endometriosis on the ART outcome. Let's welcome Dr. Chen.
Thank you, Professor Yan, for your kind introduction. Good afternoon, dear colleagues and friends. I'm Dr. Chen from Taichung here, Taiwan, Taichung Veterans General Hospital. It's my great honor and pleasure to speak at APAGE virtual meeting. My topic today is the impact of surgeries in endometriosis on the ART outcome. Before that, I would like to touch upon and quickly go through the impact of endometriosis itself on the ART outcome. As we all know, patients with endometriosis have markedly reduced monthly fecundity due to various pathophysiological effects of the disease, so-called toxic pelvic cavity, as shown here. Either ART or surgery could be applied to help them achieve pregnancy. Superficial ovarian lesions may later develop into cystic endometrioma, which exerts a local damaging effect through its highly inflammatory toxic content that will result in cortical fibrosis and speeds up follicular consumption and exhaustion. If we don't operate, the risk of intact endometriosis during ART include tracheal fluid leakage, contamination, peritonitis, infection, and difficult procedures, as well as potential poor response due to more medications are needed. Banhart from United States published in 2002 the first meta-analysis of over 5,000 patients about the effect of endometriosis on IVF, and found that significant lower chance to achieve pregnancy in these patients. The total odds ratio was 0.63 and down to 0.46 in stage 3 and 4 patients. The second meta-analysis from United Kingdom reported of nearly 9,000 patients got a similar negative effect, with reduced fertilization rate in milder endometriosis patients and reduced clinical pregnancy rate in severe endometriosis patients. In case gynae surgeons do not touch the endometrioma and let patients go to IVF directly, previous study revealed that the oocyte obtained were reduced slightly, but the fertilization rate, cleavage rate, and good embryo rate were comparable between disease and non-disease ovaries. In patients with bilateral ovarian diseases, reduced ovarian responsiveness results in fewer follicular development, However, the oocyte retrieval rates, good embryo rates, implantation rates, pregnancy rate, and delivery rates per cycle are not affected. The third meta-analysis from Brazil with over 20,000 patients concluded that women with endometriosis undergoing ART have the same chance of clinical pregnancy and live birth. The fourth meta-analysis from 12,000 patients confirmed the similar live birth rate, but they also noted the inferior outcome in severe patients. The fifth report from the same group of authors have the same conclusion of similar live births, although lower oocyte append and higher cycle cancellation was noted. The sixth meta-analysis from Italy with nearly 1,000 patients found lower clinical pregnancy rate per cycle. And this is the biggest reported series. University of Pennsylvania Barnhart Group used such data to analyze over 300,000 patients to confirm their previous finding that endometriosis is associated with lower pregnancy rate after IVF. However, the poor outcome is confounded by other factors. In patients with isolated endometriosis, their live birth outcome are just comparable to other factors. The Spanish group also reported their big data analysis and found no difference in live birth rate between endometriosis and control groups. Italian systemic review pointed out that live birth rate in stage 3 and 4 patients may be significantly lower due to their more severe disease. The UK report also confirmed that live birth rate were affected only in patients with severe diseases. The latest systemic review from UK concluded milder disease affect fertilization rate and implantation rate, but not live birth rate. However, severe disease affect all process, results in decreased live birth rate. This report from China pointed out in advanced disease, ovarian responses and oocyte competence were both affected, and finally will result in decreased cumulative clinical pregnancy rate. And this study is interesting and reveals that patients with endometriosis have the same euploid rate as their age-matched peers. And if those euploid blastocysts were thawed and transferred back to patients, the resulting live birth rate was just comparable to those in control group. This means that the endometrial receptivity in patients with endometriosis could be normal by certain conditions. Thus, ART could bypass the toxic pelvic environment and help these patients to get pregnant. By the application of frozen embryo transfer, the effects of endometriosis on ART might not be concerned anymore in the future. In our study, we also found that the cumulative live birth rate were comparable between our endometriosis and control patients. This paper will be presented in this year ASRM meeting. Let's now look at our main topic today. What will be the effect if we perform surgeries for the endometriosis lesions before the patient undergoing ART? First, we need to rethink from our previous talk. Since endometriosis probably will not affect ART outcome, what is the rationale for surgical intervention before ART treatment? Chaperon from France in Nature Review compared surgery versus ART for endometriosis-associated infertility patients. The advantage of surgery are treating cancer and ruling out malignancy. However, potential risks are negative influence on ovarian reserve, incompleteness, recurrence, and major complications. The ovarian tissue containing follicles surrounding the endometrioma might be lost during the operation, which may result in big reduction of ovarian reserve, as demonstrated by Professor Hu in this report from Taiwan. Lost nearly half of the AMH value were noted 3 months after laparoscopic surgery. Is surgery effective for endometriosis-associated infertility? According to the reviews in ICSI guideline, in women with minimal to mild disease by Jackson Cochrane review, operative laparoscopic surgery is significantly effective in improving future live birth rate, although the numbers need to treat is high, nearly 25. The only one study from Norway reported shorter time to first pregnancy and a higher live birth rate after surgical removal of minimal mild endometriosis before ART. Because of paucity of data, this does not imply the necessity of applying laparoscopy for every probable patients before ART. In women with moderate to severe diseases, which frequently present with endometrioma, surgery may result in spontaneous cumulative pregnancy rate in about 44 to 77% patients. However, all those fail to become pregnant need ART treatment. The first reported series in Taiwan in 1993 achieved similar post-operative success rate. And the first meta-analysis from UK in 2009 showed comparable clinical pregnancy rate between surgically treated and untreated patients. The second meta-analysis comprised data from Turkey, revealed the same conclusion of comparable clinical pregnancy rate. For severe endometriosis patients with deep endometriosis lesions, there exists conflict data about the effect of conservative surgery on their reproductive performance. Although some data ever demonstrated improved monthly fecundity rate in patients with complete bowel lesion resection. Similarly, the effect of surgery on ART outcome in these patients also show conflict results, as presented by these two Italian studies. Either significantly improved or negatively affected were both reported. The third meta-analysis focused on endometrioma surgery, concluded surgical treatment of endometrioma did not alter the ART outcome compared with those without surgery. The fourth meta-analysis from Italy showed lower clinical pregnancy rate after surgical treatment of endometriosis. This French study showed that both OMA and surgery increase risk of POR, poor ovarian response, but their live birth rate were not affected. The Canadian study of surgically treated endometriosis patients confirmed the presence of OMA had no impact on IVF outcome the same. However, patients with severe disease had lower clinical pregnancy rate and ongoing pregnancy rate per cycle after IVF. The fifth meta-analysis concluded surgical management of endometrioma yield lower oocyte but gets similar clinical pregnancy rate and live birth rate. This sixth meta-analysis from UK concluded the same, also show comparable clinical pregnancy rate and live birth rate by the treatment. This lovely Spanish study by Ana Cobo show us impaired cumulative live birth rate by oocyte cryopreservation after the surgery, imply that the detrimental effects by surgical excision of endometrioma in younger women, and call for our attention to perform surgery only after the fertility preservation procedure in these younger patients. The analysis from our department in this report this year in ICSI meeting demonstrated several conclusions. First, the endometrioma patient consume more COH medication compared to endometriosis-only patients. Second, blastocyst formation rates were lower in the presence of endometrioma. Third, the ART outcome of patients with endometrioma is not worse than those with endometriosis only. Fourth, the cystectomy patient still had comparable live birth rate and cumulative live birth rate compared to patients without surgery. Fifth, recurrent endometrioma did not have a worse impact on ART outcome than primary endometrioma. The data is unaliased from our patient received surgery or not. Chaperon summarized in Nature Reviews. The contemporary consensus about condition in favor of surgery is such as young patients with satisfactory ovarian reserve without other associated infertility factors or endometrioma, especially bilateral. And they also propose a shifting paradigm in which trending postponement of the conservative surgery and favoring longer-term medical treatment, and third, pursuing ART as soon as earlier as possible as the main force to achieve pregnancy. In conclusion, ladies and gentlemen, my talk this afternoon could be summarized as follows. First, current evidence shows that the impact of endometriosis per se on ART outcome is actually minimal for most of the endometriosis patients. The exception may be very severe endometriosis patients. And second, the impact of surgeries for endometriosis on ART outcome is complicated and vary depending on the instrument, the technique, and the expertise of the individual surgeon. We all hope that the operation could be performed by the hands of well-experienced surgeons, and all of our audience are such experts. Thank you for your attention. Thank you very much.
Thank you, Dr. Chen. Very excellent speech, a very comprehensive review of the current literature. And currently that we have some questions from the audience. The first is about the one question is about your clinical practice. Do you perform IVF right after doing surgery for endometriosis, or do you prefer give GnRH agonist first? And also, what's your opinion, Dr. Chen?
Okay. If for the surgery, in case the disease condition is very severe, maybe we can use GnRH before the operation, and the advantage may be reduce the blood loss, and maybe easy to do the adhesion lysis, but the disadvantage will be minimal lesion could not be evident during the surgery. So actually, it is depends on patient's individual condition to decide whether to use GnRH or not. And for the ART treatment, we usually we don't do GnRH before the ART because GnRH will hamper the ovarian response of the ovary. So if you use GnRH, then after COH, it will have a difficulty in ovary to respond to the medication. So because we have good cryopreservation facility and technique, so we can first doing the COH, then we have the oocyte embryo, then we cryopreserve. And when the disease is severe, especially in adenomyosis patients, we then can give them GnRH for 2 or 3 months, or even longer. Then after the disease becomes controlled better, then we do the frozen embryo transfer, and we can get a satisfactory pregnancy rate by this GnRH retreatment, then frozen embryo transfer policy.
So, okay, so that depends. So another question is about similarly about the if we give a GnRH after surgery. So I think that Professor Chen has answered that. But it seems that if it is for more severe cases or for adenomyosis, that depends if the patients sometimes be needed. But for endometriosis, as far as I know, the consensus is never that we don't give medical treatment currently. That the principle should be that. And so another question is about the so since do you think that do you apply the same conclusion for endometriosis for OI or IUI, or to perform rather than IVF?
Okay, and actually, the IUI for severe endometriosis is not very effective. So if patient cannot get spontaneous pregnancy, we have the diagnosis of not minimal mild, at least moderate or severe disease. After the surgery, we could, if the result is satisfactory, we could let the patient try to have spontaneous pregnancy if no other factors also involved in this couple's fertility problem. But if they have other factors such as male factor and tubal factor, etc., then the patient had better go to ART, IVF as soon as possible. And we also consider the age of the patient. If the age is younger, then they may have more time to try natural pregnancy. In patients with older age or decreased ovarian reserve, it's better to go to ART as earlier as possible.
Yes, yes, I totally agree that actually there is many confounding factors, especially the patient's age and also maybe other coexisting conditions, yes, such as especially the adenomyosis, and also that's a very complicated situation. So sometimes we have to personalize it about the treatment protocol. So one of the question is asking about the adenomyosis. Do you think that adenomyomectomy is an effective method for infertility treatment? Do you think it has treatment?
Yeah, this is a very important and interesting question. Personally, I think either medical or surgical treatment will improve the pregnancy in patients with adenomyosis. And if patient cannot get pregnant after some medical treatment, if my personal preference is persuading the patient to go to ART, because you can separate the embryo and the uterine condition. We first cryo storage of the embryo, then we treat. We can either medically treat the adenomyosis, and then when the uterine condition improves, then we do the frozen embryo transfer. In practice, this is very effective to overcome their infertility problem. But I think this medical control of the adenomyosis has some limitation. So in more severe cases, this won't be very successful. So in some patients of adenomyosis, I think surgical removal of the part of the adenomyotic lesion is necessary and may improve the pregnancy prognosis of the patient after adenomyomectomy.
Okay, thank you. But I think the adenomyosis is another complicated condition of the situation of the disease, because though the adenomyosis is so-called the endometriosis of the uterus, but sometimes the response is different from that of the ovarian endometriosis or the endometrioma. So another question is about this is a question about a case of 35 years old lady with bilateral endometrioma 3 centimeter. How do you think about it? What's your opinion? Surgery or ART first?
Yeah, the age is good, and maybe we first check the ovarian reserve of the patient. If the ovarian reserve is good, surgery is still the option. But actually, you can go to the ART directly, especially when the ovarian reserve is not good enough. And before the surgery, the 3 centimeter, maybe we can go to ART directly without any prior intervention. But in case the endometrioma is bigger and have difficulty for the oocyte retrieval, we can have drainage of the endometrioma first, and then go to the ART data.
So, okay, thank you. So the last question, because the constraint of time, that from Dr. Guo Zhang Wu, that since we can apply oocyte and embryo collection, so under this condition, do any change of your decision with the patient with endometrioma, something like that? So any modification or any change of the protocol? What's your opinion, Dr. Chen?
Just as my experience, for the adenomyosis patient, previously we don't have good embryo cryopreservation, so we downregulate the patient first to improve the adenomyosis condition. Then we do the ART, and patient can get pregnancy, but with lower ovarian response. Now we reverse the procedure. We first stimulate the patient and get the embryo cryopreservation, and then we do the medical treatment later, and then do the frozen embryo transfer after the medication. In my experience, after reverse of the condition, because patient's ovarian response better, so the success rate actually improved. This is for the adenomyosis. For endometriosis patient, I think actually if it is only the endometriosis and the CA125 level is not highly elevated, I think the patient can go to ART directly. And previously we do the fresh transfer, but because recently some group find that the frozen transfer will be have better result after frozen embryo transfer. So we just do some study to collect this data, whether fresh embryo transfer or frozen embryo transfer will have different pregnancy outcome. We still have many data to show this difference.
Thank you very much. Thank you, Dr. Chen. Because the constraint of time, we have to stop here on these topics and move on. So maybe there's a very lots of questions listed here that maybe Professor Chen will also answer these questions later.
Okay.
So yeah, thank you.
I'll answer later. Thank you.
Very excellent speech.